She integrated Western medicine and complementary and alternative therapies. Despite her untimely death, Laura's vision continues through the endowed Laura Mann Integrative Healthcare Lecture, which brings distinguished leaders to the University of Vermont to share best practices, research, innovations in integrative healthcare. The series is hosted by the University of Vermont Integrative Health, which is a joint endeavor of the University of Vermont College of Nursing and Health Sciences, the Larner College of Medicine, and UVM Medical Center. I'm really excited to introduce Dr. Donald Abrams. Dr. Abrams is the past chief of the Hematology and Oncology Division at San Francisco General Hospital and a professor of clinical medicine at the University of California, San Francisco. He has an integrative oncology consultant practice at the UCSF Osher Center for Integrative Medicine. He was one of the original clinicians and investigators to recognize and define many early AIDS-related conditions. He has been interested in clinical trials of complementary and alternative medicine interventions for HIV/AIDS and cancer, including evaluations of medicinal marijuana. He co-authored the chapter on Cannabinoids and Cancer in the Oxford University Press Integrative Oncology text that he co-edited with Andrew Weil. He also co-edits the NCI PDQ CAM Cannabinoids Committee that published the health effects of cannabis and cannabinoids, current state of evidence and recommendations for research, which was published in January of 2017. Please join me in welcoming Dr. Abrams.
Thank you. Good morning. It's a pleasure to be here. Because I am going to be mentioning cannabis during this talk, I do need to disclose some of the relationships I have with the burgeoning cannabis industry, and also another disclosure that people always laugh at, but I do think it's probably one of my most important credentials in this field. And of course, I will be discussing off-label use of an illegal substance. So what I want to do is start by talking about what integrative cancer care is. This quote is often attributed to William Osler, but it was actually said centuries before by the Hebrew sage Maimonides. It's more important to know what sort of patient has a disease than what disease a patient has. In talking about a modern definition of what integrative cancer care is, I like to say it's the rational, evidence-informed combination of conventional therapy with complementary interventions into an individualized therapeutic regimen that addresses the whole person, body, mind, and spirit with cancer. And a word that I italicized there is evidence-informed, because we're all much more used to evidence-based. And certainly as an oncologist, we are the ones who are probably the most demanding of evidence, because we deal with a very serious disease and we use very potent therapies. So we want to know before we tell a patient we're going to give you this chemotherapy, your hairs are going to fall out, you're going to be nauseated for 3 days, and your bone marrow is going to be suppressed, that there is evidence that it works. However, Andrew Weil, who is one of my teachers, always said that the degree of evidence should be directly proportional to the potential for the intervention to do harm. Hence, if I'm going to tell a patient to get a massage twice a month or eat more broccoli and blueberries, how much evidence do I really need? So that's the difference between evidence-based and evidence-informed. Integrative oncology provides relationship-centered care. Research suggests that our presence as medical or mental health clinicians, the way we bring ourselves fully into connection with those for whom we care, is one of the most crucial factors supporting how people heal, how they respond to our therapeutic efforts. I have two different practices. At Zuckerberg San Francisco General, I treat cancer, and at the Osher Center for Integrative Medicine, I treat people with cancer. So at San Francisco General, I have a 15-minute appointment, and at the Osher Center, I have an hour for my new patient. So I start all of my consultations in integrative oncology by asking my patients to tell me the story. And how long does the average physician wait before we interrupt the patient? 17 seconds. So I actually listen to the story unless it gets too long, and I say, hey, if you want to hear from me during this hour, you better cut it a little bit shorter. But the fact that I'm listening already begins to establish something of a relationship. Integrative oncology integrates conventional and complementary methods of treatment and prevention, aiming to activate the body's innate healing response using natural, less invasive interventions when possible. It encourages mind, body, spirit, and community, and encourages providers to model healthy lifestyles for their patients. Although it's against the law in California to have food in a patient care area, I do drink 5 cups of green tea every morning. So since my clinics are in the morning, I'm drinking green tea in front of my patients, and I think that's important to model healthy behaviors. Integrative oncology focuses attention on lifestyle choices for prevention and maintenance of health, and maintains that healing is always possible even when curing is not. Actually, I'm going to do a short little 5-minute film with a producer on integrative oncology, and he asked me for 3 major points that I wanted to be in the film, and I included that last bullet, and he sent me back a message saying, I'm not sure I know what that means.
Probably tell you all the details.
Hopefully you all get it. Now, CAM is something that we need to get rid of because in my mind, it's a nice acronym, it's easy to say, but it's internally self-contradictory. Because something can't be complementary and alternative at the same time. Complementary means in using with, and alternative usually means instead of. But this is a little piece on oncologists and their attitude towards complementary therapies. It's an older study, but it did note that most patients with cancer who are using complementary therapies are reluctant to discuss that with their oncologist. First of all, there's little time in the interaction to bring it up, and the oncologist is usually focused on the organ and the tumor and not so much on the bigger picture. And the oncologist might not be able to answer the patient's questions on the various therapies that they're asking about. And even more important is that patients actually feel that their oncologist might cast aside and say, go find another provider if you're going to continue to use these substances. Now, there was a small study of men with prostate cancer in the United Kingdom asking them to sort of rank their hierarchy for what they followed as far as deciding whether or not they're going to use a particular intervention. And you'll see, in contrast to what we believe, personal stories of people who had been helped by this complementary therapy were number 1, and scientific evidence was number 5. So sort of a flip of how we work in medicine, where we demand the evidence from science and not from anecdote. So I think that is something that we need to appreciate in dealing with patients. I see a lot of patients who bring me a shopping bag full of supplements that somebody told them to take. And, it really, for me, depends on where that patient is in their journey and what their potential is for cure, whether or not I'm going to just say, I don't think that's worth, or I'm going to say, think to myself, this patient is very wedded to this regimen, and what benefit is it to me to try to dissuade them from using these agents? So the patients that I see, I've been doing my integrative oncology consultative practice now since 2005. And the patients that I generally see are those who are seeking complementary therapies while undergoing conventional therapy, either to mitigate the symptoms of their cancer and its treatment or to prolong their remission. Subsequently, the other group that I see most of are those who are seeking optimal survivorship care. And some of that is sort of a product of my popularity, because it takes often patients 6 months to see me, and they come to see me and they're all done with their treatment. I said, well, why didn't you come see me when you were getting your chemo and radiation so I could be more helpful? And I said, well, I tried, but your next new patient appointment is in 6 months. So those are the 2 groups that I mainly see. People seeking alternatives to conventional cancer therapy are about 5 to 10% of people that make their way to me. I made it clear to our new patient navigator that I don't have a magic bullet for people that are not wanting to be treated for their breast cancer with surgery, radiation, and hormones, that those people sometimes make it to me. And as an oncologist for 36 years, I tell them, I'm an oncologist for 36 years, and what works, works, and I think you need conventional therapy. Then I see at the other end of the spectrum people who have run out of all options of conventional therapy and wonder again if I have some magic bullet in the drawer behind me that I can pull out and say, here you go. And finally, I see a group of patients who are seeking integrative end-of-life care. So what are my goals in my integrative oncology consultation? Well, when a person hears you have cancer, their locus of control has been ripped out from underneath them. They're now at the mercy of the surgeon, the radiation oncologist, the medical oncologist, even the chemotherapy nurse. So one of my goals in my 60-minute new patient consultation is to give the patient back some sense of control over their destiny. Inflammation, we're now aware, is one of the roots of many of the degenerative diseases of aging, dementia, heart disease, and cancer. And there's much that we can do in lifestyle modification to decrease inflammation. And I discussed that. And if you decrease inflammation, you actually increase the body's innate immunity in the fight against cancer by making the immune system not have to deal with inflammation. It can actually then turn to fight the cancer. One of my patients told me that her primary oncologist asked her if she was taking one of the new immunotherapies because he said she was behaving as if she were, and all she was doing was actually following the regimen that we worked on together. When I ask my patients to tell me the story, they often weave a story as if stress caused their cancer. Stress in and of itself I don't think causes cancer, but stress is not good for cancer, or for that matter, anything else. Stress is epinephrine or adrenaline, which is lymphocytotoxic, and stress is cortisol, which is an immune suppressant. So decreasing stress is something that we also focus on. And I think all of these things together serve to increase the patient's sense of hope. Many of the patients I see leave the office and say, gee, Dr. Abrams, you're the first person who's given me any hope. And it's not like I've told them that they don't have cancer or that they're not going to die, but just by giving them a regimen, a program of things that they can do for themselves, I think increases their hope. So what do we do to increase the patient's sense of control? Number one, weight. The CDC now estimates that 40% of malignancies in the United States today are related to overweight or obesity. And that has now surpassed tobacco use as a cause of avoidable cancer. And how do we control weight? By altering diet and increasing physical activity. I then turn to use of appropriate supplements, including cannabis. And then with regards to decreasing stress, I ask patients to become aware of their breath, because breathing is something that we do autonomically, but in turn, we can also control it with our mind by controlling the rate and depth of inspiration and expiration. And that is sort of the entryway into many of the mind-body therapies, yoga, hypnosis, etc. I ask patients to connect with family and friends. Very rarely does a patient come to see me alone. Usually they bring a spouse, a sibling, a child, a parent, or a friend, because cancer does not just affect the individual, it affects the community. At the end of my history, before I examine the patient, I talk about religion, ask if they were raised with any religious beliefs, if they currently have any, and if they consider themselves spiritual. And then in closing, I ask 3 questions. What brings you joy? What are your hopes? And where does your strength come from? Although one husband said to me when I asked his wife these 3 questions, he said, what is this? Sounds like she's being interviewed for Miss America. Others have given me a little more positive feedback. I saw a woman at a conference a few years after her husband died, and she said, you know what? When you asked my husband those 3 questions, you changed his life, because he realized even though he was dying, he did have joy, hope, and strength, and that really made his final days much more meaningful. So that was very gratifying. But I like the Miss America one as well. So I tell patients when I see them at the Osher Center, cancer is like a weed, and other people are taking care of your weed, and it's my job to work with the garden and make your soil as inhospitable as possible to growth and spread of the weed. So I look to see how you're fertilizing your garden. And what I'm telling them is that we're now going to spend about 20 minutes talking about nutrition, and particularly nutrition and cancer. And I don't know if you're aware, but this actually has been updated to 2016. This was an article in JAMA looking at the state of U.S. health 1990 to 2010. And there was, chart A was morbidity, and chart B below it was mortality. And they're basically the same. The number one contributor to morbidity and mortality in the United States today is now dietary risks, which has surpassed tobacco smoking and does not include high body mass index or physical inactivity. So if you added 1, 4, and 5, the line comes all the way out to here. So these are lifestyle issues that are now the number one cause of both morbidity and mortality in the United States today. Unfortunately, dietary risks was not defined in this article in JAMA, but they referred you to the Lancet. And this is what the components of dietary risk are. Diets that are low in fruits and vegetables, whole grain, nuts and seeds, milk, fiber, calcium, seafood, omega-3 fatty acids, and other polyunsaturated fatty acids, and diets that are high in red meat, processed meats, sugar-sweetened beverages, trans fatty acids, and sodium. So, interestingly, although most Americans can identify tobacco smoking as a cause of avoidable cancers, fewer, only 50%, recognize that diet is also responsible for cancer. And that's because it's less clear. We can quantitate pack years of tobacco smoking, but what is it about our diet? Is it what we're eating for breakfast today that's going to impact on our outcome in 20 years? Or is it what we ate during adolescence when our hormones were raging that's going to impact whether or not we get breast or prostate cancer? Or even more disconcerting, is it what our mothers ate when we were in utero? Because there is evidence in mice that epigenetics, that the phenotype of the offspring can be impacted by maternal supplements and nutrients. So we don't know the answer, and that's why it is difficult sometimes to appreciate the link between diet and cancer. But the sources that I use in having this discussion with my patients are two. The American Cancer Society every 5 years does an update of about a 30-page article that they publish in the journal CA, Cancer Journal for Clinicians. The World Cancer Research Fund, American Institute for Cancer Research, every 10 years puts out an update of their food, nutrition, physical activity, and the prevention of cancer, a global perspective, which is a 700-page document which was just re-released. This is the old cover from '07. They just re-released it in May of 2018, and they made some interesting changes that I'll allude to. But from the prior guideline, the number one recommendation, these are recommendations for reducing the risk of cancer, but number 10 says for cancer survivors, follow the 9 guidelines above. And number 1 is to be as lean as possible without becoming underweight. And I think, you know, that we have mainstreamed obesity in the United States today, where we don't really appreciate it as a medical problem, but something that's just culturally has become quite acceptable. But I think it's important to appreciate that it is a major cause of morbidity, and the American Institute for Cancer Research estimates that obesity-related excesses of these 7 cancers account for 115,000 preventable deaths a year in the United States. Now you can see the largest N is breast cancer. Only 20% of women have breast cancer that's felt to be related to obesity, These are generally women with postmenopausal estrogen receptor positive breast cancer. But since so many women have breast cancer, that N is the greatest. Look at endometrial. 50% of endometrial cancer is felt now to be related to overweight or obesity. The AICR in their 2018 version now includes 13 different cancers that are related to overweight or obesity. Most of them are in the GI tract, but interestingly, a quarter of all renal cell carcinoma is felt to be associated with overweight or obesity. Well, how is it that obesity leads to increased risk of cancer? Certainly for the breast and the ovarian and the uterine patients, body fat increases estrogen production, and those are malignancies that are driven by estrogen. Body fat also increases cytokines that promote inflammation, and I mentioned that one of our goals is to decrease inflammation, and when you have increased inflammation, you're also going to impair immunity. In my opinion, I think the most important thing that's going on here is that too much body fat is triggering insulin resistance. Thus, the body needs to produce more insulin and insulin-like growth factor, both of which promote inflammation, and the growth factor is also a growth factor for cancer cells as well, to the point where we're now looking at blockade of insulin-like growth factor 1 receptor as a treatment for a number of cancers. I believe the first study was in estrogen receptor positive breast cancer. The second guideline says to be physically active for at least 30 minutes a day. How many of you do that? Well, this is Vermont, so okay. But there was an article in Newsweek in 2000 looking at the habits of older Americans, and people over 55 said it was easier to quit smoking cigarettes than it was to institute exercise for 30 minutes each day. So it is something that other people find more difficult to do. And in fact, we know that it is important for people living with and beyond cancer, and you have a cancer rehabilitation program here that I was learning about that's very interesting and exciting. This is a meta-analysis of 16 breast and 7 colorectal cancer studies looking at about 50,000 survivors, and the bottom line is that those patients with breast and colorectal cancer who are the most physically active survived better than patients who didn't. We also know that physical activity decreases the risk of breast, colon, and prostate cancers, 3 of our most common malignancies. But what about oncologists? Do we ever talk to our patients about doing more physical activity? No. The majority of a group of non-small cell lung cancer survivors actually wanted to be told to do physical activity, and most of them actually preferred having that information given to them by somebody at a reputable cancer center. A survey of Canadian oncologists showed that 62% agreed that physical activity was safe and beneficial, but only 42% ever recommended it, and only 26% within the past month. If an oncologist recommends increased physical activity, it's generally resulted in an increase of 60 minutes of vigorous walking per week. So it is important for us as healthcare providers to understand and recommend physical activity. Guideline number 3 was changed in 2017. It used to say limit consumption of energy-dense foods, and now they changed it to avoid sugary drinks. In the current version, they brought back this as number 3, but they said limit consumption of fast foods, because they can feel that fast foods, which are processed foods high in added sugar, low in fiber, and high in fat, are the major contributor to the obesity epidemic. So they made that a separate guideline, and they actually changed the wording of avoid sugary drinks to avoid sugar-sweetened beverages. Why that is unclear, but in 2007, when they unveiled this as a new guideline, actually went to the microphone and said, there are sugary drinks and there are sugary drinks. You can drink Coca-Cola, God forbid, or Tropicana fruit punch, which is probably glucose and high fructose corn syrup, or you can squeeze 3 oranges in the morning. And the response from the podium was, energetically, they're all the same. So I had lunch with Robert Lustig, who's our pediatric endocrinologist who fights the war on sugar, and he said, if you eat an orange, the fiber slows down the absorption of sugar into the bloodstream. If you squeeze the sugar away from the fiber, it's like drinking a Coca-Cola. So why is that bad? When the body sees that sugar, it responds with insulin and insulin-like growth factor. As I said, both promote inflammation, and the growth factor is a growth factor for cancer cells as well. So does it mean I don't squeeze my 3 oranges? I used to do it every day. Now I just do it twice a week. But sugar, in my opinion, and in theirs, is the #1 no. And sugar, the average American consumes 100 pounds of sugar a year. I'd like to see this after 2008, because 2008 is when high fructose corn syrup started to get a bad name, and I would presume that the green line is down and the blue line is up. I would urge you all to perhaps download the film, That Sugar Film. This is an Australian guy who doesn't eat sugar, who decides that for 6 weeks under medical supervision, he's going to consume the average amount of sugar consumed by the average Australian, which is 40 teaspoons a day. And he's going to do it without eating junk food. And I won't give away the end of it, but it's sort of supersize me for sugar. So again, insulin-like growth factor, when they impact with the insulin-like growth factor 1 receptor, lead to intracellular changes which increase protein synthesis in the cancer cell, leading to increased cell proliferation and decrease apoptosis. So my cancer patients are always wanting to know about this juice or that juice from this exotic fruit because somebody told them it's going to cure cancer. Even clinical trials have suggested that men with prostate cancer can slow down their PSA by drinking 8 ounces of cranberry juice a day. I say no. That's one situation where I tell patients I prefer for to use a supplement of pomegranate as opposed to drinking pomegranate juice, because it's all just sugar. Well, what about metformin? Watson, of Watson-Crick, who discovered DNA, believes that metformin actually selectively kills cancer stem cells. And he says, in our midst, we have a very potent adjunct to cancer chemotherapy. Currently, there are about 200 clinical trials going on looking at adding metformin in various situations of patients with cancer who don't have diabetes. This all comes from the fact that epidemiologic studies suggest that diabetics with cancer, diabetics treated with metformin have lower rates of cancer, and diabetics with cancer on metformin do better, for example, than diabetics on insulin. So there are now, again, 200 clinical trials looking at the impact. And metformin, by the way, is a natural product derived from the French lilac. The 4th guideline, now it's maybe, actually this is number 3 now, is to eat more of a variety of fruits, vegetables, whole grains, and legumes. And in fact, we don't do very well as a society meeting the recommended requirements. It's suggested that people should have 1.5 to 2 cup equivalents a day of fruits and 2.5 to 3 cup equivalents a day of vegetables. And less than 25% of Americans meet those requirements, and among young people, less than 10%, and that's even counting ketchup and French fries as 2 different vegetables. So I'm a big fan of phytoestrogens, soy foods, flaxseed. I don't think we can ever get enough cruciferous vegetables. Mostly when I'm at home for breakfast, I eat broccoli, tofu, and rice. My other breakfast is mochi, which is just pounded brown rice. I smear almond butter and put a sweet potato on top of it, because orange yellow vegetables are also good for you. Season with ginger, garlic, onions, and turmeric. I mentioned green tea, 5 cups a day, and then the omega-3 fatty acids. I just spoke at a Facebook event in downtown San Francisco. It was plant-based living. And I had to sort of, upset the panelists and the woman who invited me by saying, there's no society that's had veganism as a diet that's survived. And clinical trials or epidemiologic studies have shown that pescatarians actually have lower rates of malignancy than people that are vegetarian, colorectal cancer anyway, than vegetarians or vegans. So I came out and said, I'm vegan until dinner, and at dinner I eat my animals. Not my dachshunds, but my fish and my, yeah. So I think we need omega-3 fatty acids. So soy, I mentioned tofu. Soy is really something that confuses a lot of people. Should I take soy if I have estrogen receptor positive breast cancer? Actually, the studies have suggested that soy decreases the risk of recurrence in women even on tamoxifen, because soy is felt to be a selective estrogen receptor modulator, just like tamoxifen. So a large study done at Kaiser was confirmed by a large study in Shanghai, and also the Women's Healthy Eating and Living analysis confirms the benefit of soy. So when we're eating soy, I would eat a whole soy food, soybean, soy milk, and some people are questionable as to whether tofu and tempeh are whole soy foods or not, and miso, and not soy cheese, soy turkey, and soy hot dogs. And I think soy is better, as is everything, if it's organic and non-GMO. Guideline number 5 says limit consumption of red meats, beef, pork, and lamb, and avoid processed meats. And avoid is a pretty big word, and I have a feeling, sort of a paranoid feeling, that the processed meat people got to the American Institute of Cancer Research, World Cancer Research Fund, because their guideline has changed in 2018 to say limit consumption of red and processed meats. And I would prefer limit and avoid, because I don't think processed meats are good for anybody. But this shows the linear relationship between intake of red meat and the development of colon cancer in women. This is an old slide, but the US and New Zealand have now been replaced by the Czech Republic and Japan due to globalization of our standard American diet. So what is the problem with red meat? Omega-6 fatty acids have gotten a bad name, but we need omega-6 fatty acids. If you cut yourself, you want your platelets to aggregate, and you want to get red, hot, tender, and swollen, because inflammation is part of normal healing, and that's what omega-6s do. Omega-3s, on the other hand, are anti-inflammatory, thrombolytic, and they've gotten, promoted to being the end-all and be-all. Well, we do need to have a little bit of both. The average ratio of omega-6 to omega-3 in food in the last century was 2-to-1, and now it's 15-to-1. Oops, what did I do? So demonstrating that omega-3s are good is a study that was done in men with prostate cancer conducted at UCLA. 48 men who were undergoing radical prostatectomy were randomized to an experimental group that had a low-fat diet, 15% of calories from fat, and they were supplemented with 5 grams of fish oil. Now, that's a lot of fish oil. Or they had a control Western diet without fish oil, so the difference was 40% of their calories were from fat, and the real difference was in this experimental group, the omega-6 to omega-3 ratio was 2-to-1 compared to 15-to-1 in the patients on the standard diet. And unfortunately, they chose measurement of insulin-like growth factor 1 levels as the primary endpoint. I say unfortunately because no effect was seen on serum insulin-like growth factor 1 levels. However, the patients in the low-fat, high omega-3 group had lower omega-6 to omega-3 ratios in both their blood and their prostate. Their prostates were smaller, both the benign and malignant component, and reduced cancer cell proliferation as measured by Ki-67 index was also seen in the patients on the experimental diet. And if you took blood from those men on the experimental diet and mixed it with prostate cancer cells in vitro, it inhibited their proliferation more than the experimental group. So I mentioned 5 grams seems to me a lot. Andrew Weil, in his book Spontaneous Happiness, talks about treating his depression with omega-3 fatty acids. And he said he took 4 grams a day of omega-3 fatty acids. Now, personally, I take 2 grams in the morning. And I said, well, I'm not depressed, but I wonder what 4 grams a day of omega-3 fatty acids is going to do to me. So I tried it. Now, I know in Ayurveda, fish oil is a bowel lubricant. And in fact, that's what happened to me. It wasn't unpleasant, but it was frequent and easy. So I often recommend to my older patients who are having difficulty with that, try 4 grams of omega-3 fatty acids. I think 5 would be a little too much. So it's not just the omega-3 and 6 in meat that's the problem. I see a lot of cancer patients who say, I'm anemic, I'm going to take iron. Iron actually feeds cancer cells. So if you're not iron deficient, don't take iron. And it's the heme iron in red meat that also increases the risk of colorectal cancer. Nitrates from the processed meat are also positively associated. That's why I'm sorry that they took out the avoid in front of processed meats. And unfortunately, we live in a culture that likes to barbecue. And when you burn flesh, heterocyclic amines are also carcinogenic. I'll have the half-pound double deluxe bacon steer burger, please. You want chemotherapy with that? So one question that we're often asked, and in fact I'm going to give a whole lecture on it, does it really matter after a cancer diagnosis? At the Osher Center, we ask all of our new patients to fill out a little sheet on what they eat. And you can see this new patient that I saw had a little bit of work to do. So Jeffrey Meyerhart at the Dana-Farber published 10 years ago results from a study of adjuvant chemotherapy for patients with colorectal cancer. And he identified 2 major patterns of food consumption, the so-called Western pattern characterized by high intake of meat, fat, refined grains, and dessert, and a more prudent pattern characterized by high intakes of fruits, vegetables, poultry, and fish. And these patients received adjuvant chemotherapy for stage 3 rectal cancer, and then they were followed for outcomes. And what he found was that those in the lowest quintile of the Western diet, they were the reference group, and those in the highest quintile had a 3-fold increased risk of recurrence and a 2-fold increased risk of death. So yes, it does seem to make a difference. I actually called him because I wasn't clear on what the difference between this group and that group was. So he told me in a personal communication that the patients over there on the right had 1 serving of red meat a day, 5 servings of refined grains, and 2 sugary desserts. And the patients over here on the left in the reference group had 2 servings of red meat a week, 2 servings of refined grain a day, and 3 desserts a week. So he concluded the recommendation is more of an avoidance than an increase in diet components. So the other thing I do at the Osher Center is evaluate patients' bag of supplements. And they always want to know, can I take this? And I sit here very studiously with my tea, in fact, on the exam table, and pretend that there's an answer to the question, because we haven't done the studies looking with capecitabine plus saw palmetto. These studies have not been done, but I just sort of intuitively or from the information that is published, I do try to give some sort of a yes or no. And the 2 major things that we as oncologists are concerned about are possible botanical pharmaceutical interactions via the cytochrome P450 isoforms. These are anti-cancer agents that are metabolized by cytochrome P450-3A4, and these are some botanicals that may work on that pathway. Now, St. John's wort, which is used for treatment of mild depression, has been studied the most as an inducer of the CYP3A4 enzyme system. And it's recommended that cancer patients never take St. John's wort during active therapy because what it does by inducing the enzyme system, it breaks down the pharmaceutical agents faster so that lower blood levels are achieved and the drugs become less effective. On the other hand, something like ginkgo, which people use for memory but I can never remember to take, inhibits the enzyme system such that the drugs will be broken down more slowly and they'll become more toxic. Let me just say that cannabidiol, or CBD, which has become very popular, and in some states it's the only legal form of cannabis available, is an inhibitor of cytochrome P450 3A11, which is also involved in the metabolism of a number of agents, and it's something I'm concerned about for patients that are using highly concentrated CBD preparations. The other major thing that we fear with patients using supplements during chemotherapy, and particularly radiation therapy, is this antioxidant-oxidant interaction. Radiation therapy works by creating free radicals of oxygen that knock into the tumor DNA and disrupt it. And some chemotherapeutic agents do the same. So oncologists, and particularly radiation oncologists, are very concerned about patients receiving active cancer therapy, taking antioxidants, because they, in fact, may negate the benefit of their conventional cancer treatment. So these are the strongly oxidative chemotherapeutic agents, the platinums, the alkylating agents, and some of the anti-tumor antibiotics. And these are some of the antioxidants that our patients may be wanting to take. So what is my general approach? Again, if our goal is to cure the patient, I'm going to err on the side of caution because I am an oncologist. So I'm going to tell the patient, let's delay supplemental antioxidants until you finish treatment. Now, my colleagues at the Breast Cancer Center across the street tell their patients not to take antioxidants the day before, the day of, or the day after their chemo. Well, that, I think, is treating the oncologist more than the patient, because it doesn't take into account the half-life of either the antioxidants or the chemotherapy. I don't like that one. I see many patients who are told, my radiation oncologist told me I can only eat white food while I'm getting radiation. White food, totally devoid of any nutrients. I say it's okay to eat antioxidant-rich foods. When it comes down to a fight between that blueberry and that beam of radiation, I think it's clear that the blueberry doesn't have a chance. And in fact, we oncologists use potent intravenous expensive antioxidants to protect patients from the effects of chemo, and we don't worry about whether it interferes with anti-tumor activity. So the supplements that I think it's okay for people to take while they're receiving standard conventional therapy, vitamin D3, the sunshine vitamin. You guys are up north here a little bit, and I understand have a pretty long winter. Most of us are vitamin D deficient. The only blood test I do for my OSHA patients is 25-hydroxy-D, and I try to supplement to bring patients into a range of 40 to 50 nanograms per ml. The World Health, or the Institute of Medicine, lowered the lower limit of normal from 30 nanograms to 20 because so many of us are insufficient that they just lowered it. And I don't think that's right. So I like people to be between 40 to 50. Vitamin D3 is fat soluble, so it needs to be taken as a gel bead or a liquid and not complex to calcium as many people take it. Because as a white powder in a tablet or a capsule, it's not very well absorbed. So I like a little gel bead. Calcium and magnesium, I think, are important for many reasons. Calcium does seem to decrease the risk of colon cancer, may increase the risk of prostate cancer, so there's a little bit of balance there. Basically, I have my patients take calcium and magnesium because I ask them to avoid dairy, and dairy is the major source of calcium in our diet, followed by green leafies and tofu. Omega-3s are anti-inflammatory and antidepressant, good for the brain, and I mentioned bowel, so I like omega-3s. I'm a big fan of medicinal mushrooms, and in Asia, which is a much more fungophilic society than our own fungophobic society, people have used medicinal mushrooms in conjunction with chemotherapy and radiation and published results demonstrating improved outcomes. If you go to the NCI PDQ page, we have a whole posting now on medicinal mushrooms in cancer patients. I'm often told by my cancer patient that their oncologist told them to stop their medicinal mushrooms because their liver function tests increased. I said, oh yeah, and that's not from your chemo? It's usually the chemo, not the medicinal mushrooms. Turmeric, everybody knows that turmeric is a very potent anti-inflammatory. The first I ever heard about turmeric was at ASCO, our traditional American Society of Clinical Oncology conference, where investigators at Ohio State have a mouse model of colon cancer, and if they fed these mice a turmeric-enriched diet, not only did they not develop colon cancer, but they survived longer than the control animals. Because turmeric is not absorbed from the GI tract, and it does its chemopreventive work locally because it gets all the way down to the colon. It also has anti-inflammatory effects and may potentiate some chemotherapy. And then since chemotherapy is a very potent antibiotic, I recommend that my patients take every once in a while a probiotic. I like probiotics that are refrigerated and contain lactobacillus and bifidobacterium. And then finally, one of the supplements that I recommend, a botanical, is our friend Cannabis. And when we look at symptoms that our patients have, weight loss, cachexia, satiety, anorexia, pain, anxiety, depression, nausea, and vomiting, there's one recommended treatment that I can make that will cover all of those different indications, and that is cannabis, which, again, has a paucity of published information, largely because of the fact that the only legal source of cannabis in the country is NIDA, the National Institute on Drug Abuse. And NIDA has a congressional mandate that they can only study substances of abuse as substances of abuse. So if you want to study cannabis as a potential therapeutic intervention, you have to use NIDA cannabis, but they cannot fund the study. So NIDA funds hundreds of millions of dollars a year of research into the harmful effects of cannabis, but cannot provide us with funds to look at its potential beneficial effect. So when I began to be interested in studying the health effects of cannabis, my oncology colleagues say, gee, Donald, in these days of nanotechnology and genomic therapies, why do you want to study a plant which is so imprecise? During my integrative medicine fellowship, what really spoke to me was Chinese medicine, in which they use a lot of whole plant products and believe that if you remove the single most active moiety and take it separately, it's a whole different medicine because you removed it from the stroma, the yin and the yang that the plant provides. So it's true that the plant has 400 different chemical compounds. The highest concentration of the bioactive compounds is in the resin exuded from the flowers of the female plant. And the main psychoactive component is delta-9 tetrahydrocannabinol. Now we feel that there are about 150 other 21 terpenophenolic cannabinoid compounds in the plant. Some of them may also have medical benefit. For example, delta-8 tetrahydrocannabinol has been studied in Israeli children getting chemotherapy, was found to be as potent an antiemetic as delta-9. CBD has catapulted to the top of the world's favorite cannabinoid because it's not psychoactive. Well, that's not true. It is psychoactive because it is anti-seizure, it's sedating, and it helps people sleep. It's not intoxicating, or it doesn't lead to a high or euphoria. We live in pretty much a puritanical, I don't need to tell you, you live in Vermont, Judeo-Christian derived society that doesn't believe that euphoria is something that we need to strive for. So that's why CBD has jumped, thanks to Sanjay Gupta and all, to the top of the most favored cannabinoid list, and I think that's a problem because it doesn't actually complex with the CB1 receptor in our brain. So how it works is very unclear to me. So I was fortunate to be one of the 16 members of the National Academy of Science, Engineering, and Medicine committee that reviewed the health effects of cannabis and cannabinoids. And these are published in the therapeutics chapter, what we felt were the strongest conclusions. And you'll see in adults with chemotherapy-induced nausea and vomiting, oral cannabinoids are effective antiemetics. And that comes from research that was done in the 70s that approved dronabinol and nabilone for the treatment of chemotherapy-induced nausea and vomiting in 1986. So oncologists really have the longest experience with cannabis medicines. In the interest of time, I'd like to just talk about the current belief that cannabis may actually have an impact on cancer itself as opposed to symptoms, where I find it to be most useful. The first suggestion of this came from our own National Cancer Institute, where investigators in 1975 published a study showing that delta-9, THC, delta-8, and CBD all inhibited Lewis lung adenocarcinoma cell growth in vitro and in mice. And since that time, this line of research has left our coast and gone to Spain and Italy, where there's an increasing body of preclinical evidence suggesting that cannabinoids may have anti-cancer activity. And cannabis itself is an antioxidant, a mild antioxidant, and anti-inflammatory. And I mentioned these receptors. We have CB1 and CB2 receptors throughout our body, CB1 predominantly in the brain, CB2 in cells of the immune system. And there's a possibility of anti-tumor activity by way of interaction with these cannabinoid receptors and the cannabinoids. Now again, Manuel Guzman at Complutense University in Madrid has done the most work on this. His lab studied the effects of cannabinoids on metabolism, and the most highly metabolically active cells in the body are brain. So they grew up mouse brain cells and they added cannabinoids to tissue culture. They said maybe we can do this faster if we use a glioma, a mouse brain tumor. So they grew it up and added cannabinoids and everything died. They said, oh, maybe we did something wrong, so they did it again and everything died. They said maybe this is a bad batch of cannabinoids, so they went back to the normal brain and everything lived. So since that time, they've demonstrated quite clearly that cannabinoids induce programmed cell death in these mouse brain tumors. In addition, cannabinoids also reduce expression of vascular endothelial growth factor and VEGF receptors, very similar to what bevacizumab for $100,000 a year does. And in addition, cannabinoids decrease the activity of an enzyme called matrix metalloproteinase 2, which allows cancer cells to become invasive and metastasize. And despite the above, normal brain cells are unaffected. When you take human tumors and transplant them into nude mice, these are the tumors that seem to respond to cannabinoids. So for me, it's very disturbing, however, that our patients are being told on websites that they can cure their own cancer using highly concentrated CBD or tinctures of tetrahydrocannabinol. Again, because I have a long wait for a new patient appointment, I am very distressed to see people who have a potentially treatable malignancy wait 6 months to see me treating their malignancy with cannabis oil, hoping that I'm going to tell them they did the right thing when now they have metastatic disease and can't be cured. In conclusion, I just want to talk a little bit about acupuncture. I mentioned my attraction to traditional Chinese medicine, and it carries over into my sort of requirement that most of my patients getting active chemotherapy and radiation be seen in consultation with a traditional Chinese medicine practitioner. Andrew Weil always says that traditional Chinese medicine is all about expelling evil and supporting good. Modern medicine focuses on expelling evil. Coming to see me, I try to support good, but when you go to traditional Chinese medicine, they do both at the same time from a different angle. So they won't say you have metastatic breast cancer, they're going to say you have decreased spleen qi and increased kidney yang, and they'll treat that. And I think for many of our patients, using all the tools in the toolbox is a good idea. The NIH had a consensus conference in 1997, which concluded that acupuncture was effective as an antiemetic during chemotherapy. Since that time, many other indications have been evolved. I think a very interesting one is xerostomia, dry mouth, in patients getting radiation. If they get acupuncture while they're getting radiation, much less likely to get xerostomia. Talking about breast cancer, it's known that about 30% of women on an aromatase inhibitor will stop aromatase inhibitor therapy because of their musculoskeletal symptoms. And this is a study in 51 women randomized to true or sham acupuncture. Whether or not you can actually do sham acupuncture is another question. But out of those 51, 38 were ultimately evaluable. And at 6 weeks, pain was reduced 50% in the true acupuncture from baseline, with no change in the group getting sham acupuncture. Other studies demonstrated that acupuncture is very useful for hot flashes, both in women and men who have hot flashes from their cancer therapy, cancer-related fatigue, xerostomia I mentioned, and we worry about whether or not we can do acupuncture in patients on chemo with low white and counts and platelets because of infection and bleeding, and that really doesn't seem to be a problem. So this is our Center for Integrative Medicine at the University of California, San Francisco. It was going to be a 3-story building, but the university decided that's a waste of money. Let's build a 5-story building. So general internal medicine is on the 1st and 2nd floor. This is our research floor. This is our clinic, and this is education and administration. And this is the cancer center over here, or what used to be our main cancer center. It's now moved across town to a much bigger campus. So I always say that I'm bridging the gap across Divisadero Street by allowing patients to come to the Integrative Medicine Center. Actually, I've just started group visits at the new cancer center where I see 5 to 9 patients in a 2-hour group visit, which is really quite fun. So in conclusion, just remember the role of the physician is to cure sometimes, heal often, and support always. And with that, I'll stop, and thank you for your attention. I don't know, do we have time for questions? I don't have my hearing aids in, so I'm going to walk around.
Can you talk about the gap that you span, in that on one hand you're an oncologist,
Yeah.
on the other hand you're taking care of the garden versus the weeds. And why is that? Is it the system that's forcing you to do that, or do you think that these are 2 roles and it would actually be hard to mix them?
Yeah, I don't think the question is, why do I do the garden in one place and the weed in the other? I'm a Gemini, so I can handle that sort of split. At San Francisco General, I deal with patients who are socioeconomically disadvantaged, and I cannot talk to them about eating organic or doing yoga, because as I often say, for most of those patients, cancer is the least of their problems. They're homeless, they're addicted, they're psychotic, or they're undocumented. The cost of my organic apple is what they could get a double cheeseburger, fries, and a shake for. So that's unfortunate. So I personally could not do integrative medicine to the extent that I do it at the Osher Center at Zuckerberg San Francisco General. Somebody like Keith Block in Evanston, Illinois, who's one of the founders of integrative oncology, although he's not actually an oncologist, has a whole center where he does do both at once. And there are other people who try to, but I think, to be honest, the complexities of 21st century oncology really make it impossible for any general oncologist or oncologist with a specialty to also embrace and encompass all the information that I need to know to do what I do too. So it's a great question. Hope I answered it. Yes?
When you're building your teams, who are the people who are part of your integrative team that support people trying to carry out your recommendations?
So who are the support? At the Osher Center, we have about 4 integrative oncology practitioners, physicians, nurse practitioners. We have 6 acupuncturists. We have 2 massage therapists. We have a biofeedback person. And we have a lot of group mindfulness-based stress reduction, laughter yoga, yoga, and I have a personal trainer that Our Cancer Resource Center allows us to give one free consultation or workout with the personal trainer. So that's just off the top of my head. Our own acupuncturists are so busy that they can't see patients, sort of like how busy I am. So I have asked all my patients who are getting acupuncture in the community who they're seeing, and I have a list by different locales in the Bay Area so I can refer patients to more local acupuncturists. Yes?
If you could address turmeric and tamoxifen, since breast cancer is such a large percentage of
you
the
know,
cancers.
patients tell me about it, but I think it's more of a theoretical concern of an interaction than a real one, but I don't know the answer. Yeah.
Talk about avoiding sugary drinks. What about wine?
Sure. What about wine? Great question. So wine is not refined sugar, and I tell my patients that thinking about beverages, think red and green, Christmas, so red wine and green tea. So red wine has more resveratrol, which may have some life-prolonging benefits. I prefer red wine to a capsule of resveratrol. 1 gram of resveratrol is the amount of resveratrol in 667 bottles of red wine. The guidelines used to be, if consumed at all, limit alcohol to 2 a day for men and 1 a day for women. And for me, that was always very hard to explain to patients, if at all, 2 a day, because that seems like a big dichotomy. I've reached an age where my liver does not like alcohol anymore, so I can't drink, and it's been a few months. I used to like my red wine and my vodka with olives, but can't do it anymore. So the guideline this year says for cancer prevention, no alcohol is best. And the foundation that anyway, they just published a health burden, the burden of disease on alcohol in 195 different countries. And they say, again, for disease prevention, no alcohol is best. That the whole alcohol is good for heart and diabetes protection is not supported by the data. The Bill Gates Foundation just published it a month ago.
2 questions or commentary on. Number one, I'm frequently confused because we
You're
see.
not holding it.
Yeah, I'm frequently confused because we see patients who are using marijuana and getting cyclical vomiting syndrome, and we're also using it to treat nausea. So I wonder if you have a comment on that, and then a follow-up.
One at a time,
Okay.
because it's early in my morning and I'll forget. So I've never seen cyclical nausea in 36 years of patients using cannabis, but it is something, as more people use cannabis, that is becoming more recognized. And I guess it's because of an aberrant, if it's antiemetic and some people have a different SNPs in their CB1 receptor, maybe it's causing a idiosyncratic response. So it's, and that's the one where people benefit by taking a shower. Yeah.
So the second, I wonder if you have any comments on T. Colin Campbell's research or what he's talked about in terms of vegan diets. You mentioned that earlier. I don't know if you've read any of his stuff at all.
Who is it?
T. Colin Campbell.
Oh, yeah.
The China study.
He's a militant vegan, right? Yeah, there are a lot of militant vegans. I also recommend the film What the Health, which is it's a very important film for those of us that are health professionals to see, because the whole basis of it is that organized medicine is keeping from patients the real truth about how important nutrition is to health. And there is some pretty creepy stuff in there, but it's a movie that's done by and focuses on militant vegans, so you have to take everything with a grain of beef. But I don't, I mentioned what my feeling is about. I think a plant-based, my diet is organic, plant-based, antioxidant-rich, anti-inflammatory whole foods. So it's not named, it's not keto or paleo or alkaline. By the way, the alkaline diet, which many of our cancer patients love because they think cancer prefers an acid environment. There was just an article in Nature 2 weeks ago saying, in fact, acid is better to kill cancer cells than alkalis. So that is flipped on its head, as I hope the ketogenic diet someday gets flipped on its head, because in my opinion, that's the most unhealthy diet out there. Good. All right. Well, thank you for your good questions.